Well, hello everyone, and welcome back to this virtual webinar. I just want to thank the FUS Foundation for organizing all this. I think it's very pertinent right now with the number of clinical trials that are going on in the space with different ultrasound devices that are disrupting the blood-brain barrier and delivering different drugs. Today we're going to talk about confirmation of BBB opening, which I think is a pretty broad topic, and we'll see where we go with it. But it's a pertinent one as well. I think it was brought up in the last session by Graham, who brought up the question of how do we compare different devices and different BBB opening regimes across studies, and how do we compare clinical to preclinical studies. So there's a lot of different open questions, I think, in this space, and we'll see what we can do to address some of them. So my panelists today, I'll just introduce them first. We have Raag, Airan, the Assistant Professor of Radiology at Stanford University. Thanks, Raag, for joining. We have Antonis Pouliopoulos. He's Associate Research Scientist at Columbia University. And then we have Nathan McDannold, the Professor of Radiology at Brigham and Women's Hospital at Harvard Medical School. So thank you, everyone. And I thought just to kick off this panel, maybe we can just go through each of you and you can discuss, what kind of techniques you guys are using in your lab to confirm BBB opening. I think that we can see where we go with this. So Nathan, do you want to start?
Sure, thank you. So typically, most of the time we're using MR contrast enhancement as the surrogate for measuring blood-brain barrier opening. How we do it depends on the study. If we're looking at different parameters within our own group of animals, so if we're looking at say a parametric study where we compare rat A or rat B, we may do something as simple as just looking at signal enhancement. But if we're interested in something more quantitative, you can do T1 mapping and estimate gadolinium concentrations, or you can do dynamic contrast enhanced imaging to estimate the permeability for that contrast agent. Depending on, if those are a little bit more time consuming and MRI is expensive, so often we just use signal enhancement as a surrogate. We also do experiments non-MRI guided, and typically there we'll use either some sort of fluorescent tracer. We typically use trypan blue or Evans blue. But we've also looked at fluorescent dextrans. I think that's about it. We've also recently looked at doing some mass spec imaging to directly quantify drug concentrations ex vivo. And I think that is something, you can do the same thing with the gadolinium, so you can get a direct calibration that way.
Great, thanks. Raag, do you want to just talk a little bit about the work that you're doing in your lab?
Sure. For BBB opening, I mean, we follow a lot of Nathan's recipes, and similarly use contrast enhanced signal enhancement on MR as the main surrogate. We have explored using dynamic contrast enhanced MRI, and in a clinical trial would plan to have that available for the immediate post-procedure imaging. And we've also explored using acoustic backscatter analysis to quantify that or correlate that. To be honest, though, I mean, this could be a hardware limitation on our end. We haven't seen as reliable a signal using the acoustic backscatter as the contrast enhanced MR. Although we have explored on the MR side using both T1 mapping as well as the just run-of-the-mill signal enhancement. But in routine practice, rely mainly on the signal enhancement as opposed to doing the full quantitative T1 mapping for routine studies.
Mm-hmm. Okay, thanks. And Antonis, do you want to talk a little bit too about work you're doing?
Yeah, of course, thank you. Yeah, so along these lines, we also typically do T1 weighted contrast enhanced MRI, but we're also exploring other techniques, contrast-free techniques. So we have done some experiments in monkeys and NHPs, and we've seen that without using contrast, there is a change in the diffusion constant of water molecules in the area of the opening, which was really exciting to see and correlated very well with the contrast enhanced area. So we believe that another contrast-free technique is also possible without having to put this contrast again and again. And it's very important because if we want to do, let's say, weekly treatments or more often, it's really difficult for humans to be exposed to gadolinium again and again. Another dimension we're exploring is, of course, correlation with passive acoustic mapping techniques. So we're going to see the distribution of bubble activity in the brain, and there's quite good correlation between this activity and the opening area. So these are all surrogates, but of course the typical way is contrast enhanced T1 weighted imaging.
Great. And just to give you a little bit of an overview, I think we've done a lot of different work too, using different techniques in our clinical trials right now. We typically just look at T1 enhancement. I think, what you can do clinically is a little bit more limited than what you can do preclinically. We're also using fluorescein now in our intraoperative study. We're actually measuring drug concentrations, and the fluorescein works really well intraoperatively to really visualize, in the OR, the regions of BBB that you're disrupting. So that's been working well as well. But I think getting, at some of the key questions, I think are really, what work can we do to really, develop techniques that can be used to compare opening, I think, across studies is a big question. And then how much should we rely on these techniques really as a surrogate for the drug delivery? I mean, there's a lot of studies now that say, okay, the gadolinium correlates with dox or correlates with, drug Z, whatever drug you choose, and there's a decent correlation, and then we assume that it's good. But how much should we rely on these? So I don't know if anyone wants to dig into that, but I think, it's an important question, really getting at how do we compare, clinical results and this kind of like surrogate endpoint for BBB opening, across different devices. So maybe someone wants to start that. Nathan, do you want to take it first?
Sure. I mean, I think ultimately we're going to have to, especially with people using different vendors and different field strengths of MRI. So for example, using MRI for, I think that we'll have to decide either to do some sort of T1 mapping or dynamic contrast enhanced imaging. One of the things I've learned, we've done, just a handful of patients at Brigham now. A lot of the area that we've been targeting has been in white matter, and the disruption is much less evident in white matter than in gray matter. So I think that we've been acquiring some perfusion imaging, but the level of disruption there is so low, I'm not too optimistic about being able to get a reliable reading out of that. So I think some of the things that people have been looking at, with the diffusion MRI could be exciting. But I think that we need to think about also like our detection thresholds for what we can measure. And I worry that, we're not going to see great opening in white matter or other structures, and we might push things too far and start getting damage to get the opening that we can see on MRI. So I think that's one of the main questions I have is with glioblastoma in particular, is this very large infiltrating zone going into white matter, that are we getting the drug where it needs to go, and can we even see it with the MRI?
Nathan brings up obviously great points about, sorry to jump in. Nathan brings up some great points about that we've thought about ours, as well, that the cerebral blood volume and capillary density is definitely known to be lower in white matter areas versus gray matter. And it's unclear how that's translates into BBB opening in the normal white matter or the relatively normal white matter, as well as in the tumor infiltrated white matter, and so on. These are all fairly unknowns, and for protocols that have been developed in preclinical models that may or may not recapitulate the human, natural GBM scenario, it's going to be a little difficult to tell. The other kind of thing that we're thinking about is the exact timing of when we acquire our say T1 weighted MRI. If the particular procedure is done not exactly within the MRI, depending upon the device that's being used, or if it's in the MRI, but other stuff has to happen between sonication and MR acquisition. Just what is the timing, and can we maybe do we have any guidance as a field to know what is it 10 minutes after sonication we see this K-trans? What does that correlate to? And the last issue I'll raise without being productive in terms of answering it is we do have evidence from at least preclinical models that K-trans correlates with small molecule penetration. K-trans using gadolinium as a basis for small molecule penetration. However, it's not entirely clear, at least to me, or looking at the literature, that how well that's going to correlate with larger therapeutics, antibodies and so on, or antibody fragments. It's truthy to me that the gadolinium, regular Gadavist or multi-hands will correlate with small molecules like, DOX or carboplatin or so on, but I don't have a way to know how to predict about the larger agents.
Yeah, to add on that, apart from the size, it's also about the charge, the lipophilicity of the agent, and other many factors that influence how much the drug will permeate into the body, right? And one thing I guess we can do is to tag these big molecules with, let's say, a contrast agent of MRI or a PET tracer, right? And we can see how the virus permeates or how the antibody permeates through the barrier. I think that's the only way we can actually be sure about first the permeability and then the distribution of the drug in the brain.
Great, and just hearing everyone's comments, maybe one kind of interesting point is when, at least with the Carthera device and the studies that we've done, we've kind of altered when we do the MRI acquisition. In our first studies, we really did the MRI right after the sonication, and we typically gave gadolinium and then did the T1 image about 5 minutes after the gadolinium. So that whole procedure was maybe within 30 minutes of the sonication. Now we're actually trying to prioritize drug delivery and giving the drug first and then giving an MRI after, because we're getting more confident in the safety. But maybe, how is that done for the inside tech system, for example? Maybe Nathan can comment, when is that image acquired that you say there's a 20% contrast enhancement, and what's the, kind of the timing for that?
That's a really good point. So currently, the way that we're doing it at our site is that the patient is in a frame in the device, gets the BBB opening, then the patient is removed from the device, the frame is removed, the table is swapped to a head coil, and then we acquire, SWI 2-star images, and then we get the T1 baseline, and then we try to get a post phase at the end of the exam, and then we repeat it, so we get half an hour. And by the time they get their drug, it's within 90 minutes of the opening. But I agree that it would be, at this point where we're interested in the feasibility and the safety, so we're looking at the MRI. Ideally, we would give the drug as close as possible to the disruption, or depending on the drug, even before the disruption, so you get more across that way. But that's a really good point. And there is a variable delay in when we give the GAD to some extent, just from how long it takes to get the patient off and the frame off and getting back in the scanner. But we try to get it as close as we can.
Okay, that's interesting to hear. You're still giving the drug at such a long delay after the sonication.
I would love to get it before the MRI, post MRI, but they're concerned about getting sick in the MRI. So
for sure, that's a big issue. Let's see. We had a question from the audience, and it was, any reason why the FUS-BB opening is less obvious in white matter region than gray matter areas? I guess we touched on that. I don't know if anyone has any more comments about what we,
Yeah, just that the vascular density is much lower, and it's also really important because glioma like to infiltrate along white matter fibers. So it's actually a very important area to get drug to, and it's a challenge to see what we're doing.
Yep. Just adding on that, we know the cerebral blood volume is lower in white matter, and the microbubble density is going to be then correspondingly lower at the time of, and if BBB opening is a function of capillary density plus microbubble, concentration, those two factors are going against us in normal white matter. With tumor infiltrated white matter, where the blood volume might be higher, maybe we're a bit better there, but it's a bit uncharted territory in terms of trying to take models of normal or not even just rat brain, and trying to apply that to the human condition.
Great. Well, I'm getting the timer. I think our time is up for this session right now. So I just want to thank you guys all for joining this discussion, and hopefully it was useful for all the participants. Looking forward to more sessions as part of this webinar. Thank you, everyone.